So welcome all of you for this final session of the day in this hall, I suppose. This is on emerging topics, so we'll start off with the first speaker, Dr. Sasikala.
So a very good afternoon to all of you. I thank Dr. Sudipta for the wonderful arrangements and inviting me here to give this talk. And today we had a great initiative by Dr. Sudipta's team and Dr. Pramod Gar to form a group in India to study the basic science part of pancreatic diseases. I'm happy about that. Till now we have been doing this in Asian Institute of Gastroenterology. We interact on a daily basis or weekly conferences amongst ourselves, and then now it is extending to the Indian group. Thank you, Dr. Sudipta, for that. So, since morning we have been hearing about the ducts, acinar cells, the genetics, etc. Now my focus is on the endocrine pancreas. Although diabetes is a common manifestation of chronic pancreatitis, it has attracted the focus of basic scientists and the gastroenterologists only recently, that is after the WHO classified it as a distinct entity. The prevalence, the cumulative incidence of diabetes in chronic pancreatitis in the follow-up studies have been established to be around 60%. Type 3 diabetes bears distinct clinical features, and the complexity of pathophysiology is because of severe inflammation that is seen in chronic pancreatitis in comparison to type 1 and type 2 diabetes. The morbidity, mortality is high, the risk of progressing to cancer is very high, but we don't understand how it evolves. So we need to address this urgent clinical unmet need to predict, prevent and treat diabetes in chronic pancreatitis. Although we know that there is endocrine deficiency, we do not understand the molecular mechanisms as of now completely. We know that there are acinar interactions, acinar endocrine interactions, but we do not know again the molecular mechanisms. We know that this has also got metabolic dysregulation, but as of now we have no complete understanding of all this. So our interest started when we observed about 10 years back, even the diabetic chronic pancreatitis patients have sufficient islet mass. So we started looking at, we were thinking why this islet, so much of islet mass is there even in non-diabetic chronic pancreatitis patients. How is that endocrine deficiency is developing? So in that context, we started thinking that the beta cells of islets may not be functioning properly. So that's the reason why there is endocrine deficiency. And we have demonstrated that there is endocrine deficiency or insulin secretory defects that is due to, if you see here, that is due to increased cytokines in the pancreatic tissue. So later, I am very happy in the morning, Dr. Rizvi showed that there is increased interferon gamma levels. Way back in 2012, we have shown that interferon gamma, pancreatic interferon gamma, is associated with diabetes or the glycemic status in circulation. So then we showed that the source for this interferon gamma is T helper cell. This was again linked to a master regulator of T cell differentiation, which is called BAC2, and this repression of this leads to differentiation of T cells towards T helper cell rather than regulatory T cells. So this again, recently there is a paper from the PROCEED group of USA in 2023 where they said there is a role for IL-17 signaling pathway, which also corroborate with our findings, which we published in UEG journal way back in 2018. So with this background, we want to understand the exact molecular mechanism of beta cell dysfunction. This is in order to identify therapeutic targets. And the second objective of ours was to understand the metabolic dysregulation that leads to altered glucose homeostasis that can identify the risk of CP patients becoming diabetic. So towards this, we have compared the transcriptomes of mice, pancreatic tissue from mice as well as humans, and we found that there is sequential dysregulation of receptors, which we had discussed 2019 DDW. So then, at RAP stage, we found that there is a receptor which is islet specific, that's called nuclear receptor 4A1, which is upregulated in humans as well as in mice model. We wanted to see the commonly dysregulated receptor so that we are sure that this is maybe taking major role in developing insulin secretory defects. So then this is since nuclear receptor was overexpressed in the islets of chronic pancreatitis in mice as well as humans, we have overexpressed in Min6 cell to see its downstream effects. We found that both insulin content and insulin secretion both were decreased in the overexpressed cells. This is because insulin gene transcription itself is decreased because of the decrease in the transcription factors responsible for insulin gene transcription. The RNA-seq analysis identified two most important pathways, that is calcium signaling pathway and cyclic AMP pathway, which are both very important for insulin secretions. You also see here in human control subjects, this is the islet, sufficient calcium is there, but in chronic pancreatitis, these yellow bars you see, they don't have, the calcium levels are decreased. This also was seen in the overexpressed cells. Then once we treated these animals with anti-interferon gamma antibodies, that has restored the insulin secretions by decreasing the receptor, nuclear receptor 4A1 and increasing the calcium levels. So this we published in Pancreas, and we said that since this NR4A1 has got a role in insulin secretory functions in the beta cell functions, we said this needs to be modulated. We cannot block it, it needs to be modulated. The expression should be balanced so that the cells function properly. So what is the link for our earlier findings? Earlier we have shown that BAC2 is repressed and TH17 cell expression is increased, interferon gamma is increased. This is corroborating with findings from our own country as well as from US. And what is the link between this as well as our interferon gamma now? Now the increased interferon gamma levels, when they bind to the receptor, activates the STATs and interacts with these transcription factors and upregulates NR4A1, which we have all the data, but I am not able to show here due to lack of time. This increased NR4A1 results in decreased insulin gene transcription and decreased calcium channel expression. So this leads to decreased insulin secretory functions of islets in chronic pancreatitis. So this is a multi-institutional study where we involved I think 4 or 5 institutes, and we have shown that NR4A1 can be a potential target to improve islet functions in chronic pancreatitis. So then we started looking at the commonalities between the mice model of chronic pancreatitis and human chronic pancreatitis. We see that morphologically they are same, fibrosis is there, islet mass is there even in mice. What is lacking is the mice never develop diabetes. We don't have a model for studying the molecular mechanism of diabetes in mice because they never develop diabetes. We have tried with 2 models, cerulin as well as arginine, they never develop diabetes. So then we started looking at the commonalities between the transcriptomes. We already have transcriptomes, we were looking at the transcriptomes. They have all features of chronic pancreatitis. The only difference that we saw from the human transcriptome versus the animals is that these are all the genes that are uniquely expressed in humans which are not expressed in mice models. And these are the common genes which are related to insulin resistance. So when we did a string analysis, majority of these genes are falling in the insulin signaling pathway, indicating that these genes may be playing a role in developing insulin resistance in humans. That could be the reason for humans developing diabetes and not the mice developing diabetes. So this fits very well into a two-hit model as we understand. The first hit is insulin synthesis and secretory defects. The second hit is metabolic dysregulation. So then we went on to study the metabolic plasma metabolomics in 3 different hearts, and then we found that the phospholipids can distinguish non-diabetic CP from pre-diabetic CP. Our goal was to predict pre-diabetes. Who is the person who is going to become pre-diabetic? This is because we have some time. When they come to the clinic as non-diabetic patients, over a period they develop diabetes. They become pre-diabetic and then they become diabetic. So we have a window of period where we can protect them if we can understand them properly. So these 4 phospholipids, a panel was able to distinguish up to 60%. So, but we wanted to improve the sensitivity and specificity, so we also added the clinical features like BMI, age, duration of the disease, and when we clubbed these, the sensitivity and specificity increased. It can even distinguish, the lysophosphatidic acid even can distinguish T3 versus T2 diabetes. We understand definitely that there are overlaps between T3 and T2, but one thing we remember is T3 arises as a result of severe inflammation and T2 is not because of severe inflammation. So that could be one reason. And LPA, lysophosphatidic acid, is twofold upregulated in T3 diabetic patients. That's why we believe that this can distinguish T3 versus T2. This is a study definitely, but we need to validate a larger sample and multi-centric studies have to be established. So in order to use these in the clinic, we developed a logistic regression model, including the phospholipids and the clinical features. And then when we have employed this to 56 patients, chronic pancreatitis patients, who had HbA1c less than 5.7, we found that 41% of them had metabolic alterations. Only 15 people did not have metabolic alterations, indicating that these 41 patients may develop pre-diabetes. We followed these people at the end of 1 year and we found that 25% of them have already developed pre-diabetes. So this we published in Clinical and Translational Gastroenterology. However, all these findings have to be validated in larger cohorts and multi-centric, multi-institutional. We have already discussed with the PROCEED group and they are willing to send the samples. Only thing is, we will have to get some permission to get the samples from the PROCEED group to India and then do the analysis here. So we also tried to develop the pathways and we found that glycerophospholipid pathway and inositol signaling pathway are very important in this, in the diabetes development in chronic pancreatitis patients. And this is again another group, multi-institutional study which we have done. And we need a lot of expertise, mass spectrometry expertise, clinical expertise, and the basic science expertise. And in summary, nuclear receptor 4A1 is identified as a potential therapeutic target to improve beta cell functions, which needs to be further studied. Unfortunately, there are no FDA-approved drugs for nuclear receptor 4A1. The drug needs to be designed and then tested. The logistic regression model can be studied in a multicentric studies, and to see that it can be used in a clinical setting in a day-to-day practice. The lysophosphatidic acid is again another marker that we need to test in multicentric studies and use it in the clinical practice. So I thank ICMR, INSERV, and Asian Institute of Gastroenterology for allowing me to conduct this study. So based on these, the studies that we are conducting at Aegis Hospital, Wellcome Trust has granted a diabetes center to study type 2 diabetes and study the pancreas, Indian pancreas, as to what is happening, why there is so much of diabetes in India. So I thank all my funding bodies. Thank you very much.
Thank you so much. It was wonderful. Ma'am, I have just one question. The patients in the last part of the data that you showed some metabolic alterations. Can you just expand on what kind of alterations were noticed in those patients who went on to develop prediabetes?
So these are the, in the first study, when we have done the plasma metabolomics, we found that the phospholipids are increased in pre-diabetic condition, not in the diabetes. When they become diabetic, the value goes down again. Only in the pre-diabetic condition, they are increased. And these are lysophosphatidic acid, phosphatidylienositol, phosphatidylglycerol and ceramide. We have a panel of these 4 phospholipids which can distinguish non-diabetic CP from pre-diabetic CP. So that's the reason. It's only up to 60%. We could not get 90, 85% sensitivity, specificity. So that we included the clinical features like age, BMI, duration of the disease, calcification, atrophy of pancreas, the features of chronic pancreatitis. So then we could get 92% specificity and 80% sensitivity. So to use it in a clinical, this is a study, okay, very well accepted, published. But how do we use this in the clinical setting? So that for that reason we developed a regression equation. There's an equation, but it needs to be validated. We found that when we use this, when the score is above 0.5, all those people who have metabolic alteration have a score of above 0.5. People with score below 0.5, they were all non-diabetic. They did not have metabolic alterations.
Thank you, ma'am, for your wonderful talk. What about type 3A and B diabetes? Is it so? What the topic that you talked about is?
Our focus is only type 3C diabetes because 80% of type 3 is constituted by chronic pancreatitis.
So that's type C.
Type 3C.
So how is this lysophosphatidic acid measured?
So since this is a study, we have used mass spectrometer.
Okay.
So it's done in 3 phases. One is untargeted metabolomics. We have studied the global metabolomics of these patients, non-diabetic, pre-diabetic, diabetic. Then from there we have validated a few which were significantly different.
Okay. So there must be methods available apart from mass spectrometry to measure.
Are there, but for this kind of molecules, ELISA is not suitable. It's not very sensitive.
Because your findings, you say that this can differentiate between type 2 and 3 diabetes. Okay.
But needs to be validated in larger studies. Okay. We have done 300 patients.
Thank you, ma'am. Any more questions?
Great talk. Very nice. A couple of questions. So, first question is, when you say that the lysoform and the phosphatidylglycerol or inositol change, is this in proportions as a percentage, or is it in absolute amounts that you see changes? Is it that under normal conditions it's 34% and it comes to 22%, or is it that it was in micromolars, that it was 2 micromolars and became 10 micromolars? So is it an absolute change or a relative change?
It's an absolute change. We have quantification of these.
So it's an absolute change. Okay, so second question is that you mentioned both the parent phospholipid, which is the glycerol, and the, I think, which was the other one? One was glycerol and the other one was inositol, yes. So, and the other is a lysoform. So, there would be a yin-yang, because if the lyso is going up, the parent has to go down. All right? So what do you find in going up with diabetes, and what do you find going down with diabetes?
So when the patient is pre-diabetic, it is the lysophosphatidyl phosphoglycerol pathway. Phosphatidylglycerol pathway.
Glycerol pathway is...
Glycerol pathway. When this phosphoglycerol pathway goes up, then the patient is becoming diabetic.
So when you say goes up, meaning the lysoform going up?
This one, see, if up to this it is pre-diabetic condition, and when this also increases, then the patient becomes diabetic. That's what we have observed. And these are all involved in insulin resistance, developing insulin resistance.
Yeah. So basically the lysoform, as you know, is basically a cleaved form. One of the fatty acids has been cleaved off. So it becomes a lysophospholipid.
Yes.
Whereas if it has both the chains, it's the parent phospholipid. Right?
Yes.
So basically you're saying there's a probably, like you mentioned, the phospholipase activity over there, which
Yes,
is
we have that data also. Since I have not published that and lack of time, I could not give all that data.
Sure.
Phospholipase D is increased. At tissue level we have seen phospholipase D is increased, and in this pathway phospholipid D is increased.
Okay.
That is.
So for when they become diabetic, the lysoform goes up, is what you're saying? The phospholipase D is...
That's also there, yes.
Okay.
Yes.
So phospholipase D. So last question is, which are the acyl chains that get cleaved? So when you're saying that the lysoform is going up, it's some acyl chain that is getting cleaved, maybe an arachidonyl, maybe a C22-6, maybe something else. So which one are you cleaving? What is the
So
cleave?
it's basically a C18 carbon chain,
Uh-huh.
but to be precise, I will have to get back to you.
Okay. So, yeah, it would be interesting to see that, because basically what you're saying is it's a cleavage of a membrane phospholipid of a specific acyl chain, and it'll be nice to know that is it a specific class of acyl chains that gets cleaved, or is it just a global cleavage of the acyl chain with the parent head group that gets cleaved?
Yeah, that's a good point. I'll take back.
First of all, to answer your question, type 3A and type 3B are monogenetic types of diabetes, either with cellular function that you can treat with a sulfonylurea or lack of insulin production, which causes severe neonatal. And then C, type 3C is a hodgepodge of all kinds of things, pancreatic cancer, hemochromatosis. And so trying to distinguish type 2 and type 3 is a big problem of nomenclature, because type 3C is supposed to be a loss of the islets. And what you're showing is there's no loss of islets in some cases, but there's a loss of function. However, some patients are more like mice, others are different. And so there's not a single feature that you can use to distinguish, because it's a little of each. To add more confusion to it is that the patients with chronic pancreatitis that develop pancreatitis have a genetic profile that looks like type 2 diabetes, and there may be more insulin resistance, but there's also beta cell dysfunction. And even with type 2 diabetes, it can now be subdivided into 8 subclasses based on mechanism. And so trying to just say it's type 2 or type 3, I think is going to be a problem, and coming up with a formula may or may not be helpful in individual cases. It's not going to be as helpful when you're looking for more targeted treatment. So I think that type 3C is useful to say the pancreas problem came first, but why they develop diabetes could be loss of islets or dysfunction for a variety of reasons, and may also be complemented by peripheral insulin resistance that causes accelerated islet cell failure.
Thank you very much for your comment on that. Regarding your first comment, let's say this FDA levels in a larger study. This is just a discovery study. So let's test and see whether it validates in larger studies and the multicentric studies. If it validates well and good, if it doesn't, then it's only a mechanistic understanding.
Right, and so I think that at the same time, what would be important to do, as you're doing, is trying to go through the mechanism, but not assuming everybody has the same mechanism.
Yes.
And so can you subdivide the patients? Because even with your measurements, it's not a tight correlation, it's an average with a range. And so is there a better way to take each of these different pathways that are independently important and see if it's possible to have a better understanding of what an individual person has, because that may have implications on outcome or treatment or other complications.
Sure, sir, we'll take care of it.